You know that nagging pain at the back of your heel? That one that just, well, won't quit.
Mm-hmm.
Today on the deep dive, we're tackling a really common culprit, Achilles tendinopathy.
Yeah, it comes up a lot.
Think of this as your streamlined, high-impact guide to understanding this condition inside and out, sort of perfect for locking down your knowledge.
Absolutely. We're aiming to make it really clear and memorable.
We'll be digging into what it is, what kicks it off, who's most at risk, how it actually develops in the tendon.
Right, and also what else it might be confused with, how people usually present.
Exactly. And then how we diagnose it, the treatment options, what the outlook is, and potential problems down the line. Let's just jump right in.
Sounds good. We've basically boiled down the revision notes into the core essentials you need for Achilles tendinopathy, covering all those key bases.
Okay, so let's start right at the beginning. What exactly is Achilles tendinopathy?
Okay, so at its heart, Achilles tendinopathy is a chronic issue. It comes from overusing the Achilles tendon.
And that's the big one, connecting the calf to the heel.
Exactly, that one. Connects those calf muscles, the gastrocnemius and soleus, right down to the heel bone, the calcaneus. Super important for pushing off, walking, running. And the problem, the tendinopathy, usually pops up either in the main body of the tendon, we call that the mid-substance, or right where it actually inserts onto the heel bone.
Okay.
And yeah, it's a really, really frequent cause of that posterior heel pain people complain about.
Got it. So overuse is the big headline. But what specific things contribute to that overuse becoming a problem? What's the actual cause, the etiology?
Well, the number one thing is just repetitive loading, repetitive stress on that Achilles tendon. But, several things can make the tendon more susceptible.
Like what?
Things like excessive strain, maybe pushing yourself too hard, too fast. Poor biomechanics is a big one.
How you walk or run, you mean?
Exactly. If your foot mechanics are off, it can put weird stresses on the tendon. And also, consistently, like skipping proper warm-ups before you exercise, that doesn't prep the tendon for the load.
Right. It's not just about the total amount of running or jumping, is it? I remember reading it's often about sudden changes.
Precisely. Yeah. Rapidly increasing your activity level, whether that's how long you go for, how intensely you train, or just how often that can overwhelm the tendon's ability to cope and adapt.
Okay.
Tight calf muscles are another really significant factor. If your calves are tight, they pull more on the tendon, increasing the tension.
Makes sense.
And finally, it's worth remembering that sometimes underlying medical conditions, particularly systemic inflammatory diseases, can kind of predispose someone to developing it.
Interesting. So who tends to get this more often? Who's more prone? What are those key risk factors we should be looking out for?
Yeah, there's a pretty well-defined group, or rather a set of risk factors. Age is one. As we get older, tendons generally become a bit less resilient. Men also seem to get it more often than women. Participating in sports that involve a lot of jumping or running is a major one, obviously because of that repetitive stress.
Right, the high-impact stuff.
Exactly. And obesity, too, carrying extra weight, increases the load on the tendons with every step.
Okay, so older age, male, certain sports, higher body weight. What else adds to the risk?
Well, certain chronic medical conditions have been linked to things like diabetes, high blood pressure, and high cholesterol. And interestingly, specific medications can play a role. The big ones are the fluoroquinolone antibiotics.
Oh, like ciprofloxacin.
Exactly, ciprofloxacin. Those have been associated with tendon inflammation and, worryingly, even an increased risk of rupture. So definitely something to be aware of.
Wow. Okay.
Having a previous injury in that area to the Achilles or nearby structures also makes you more susceptible. And like we just said about the causes, those sudden increases in activity, duration, or intensity are a big risk factor.
Anything else? Shoes, maybe?
Yes, absolutely. Changes in footwear or even the surface you train on, like switching from grass to road, can contribute. Poor running technique, particularly if your foot rolls inward too much, what we call excessive pronation, that can put extra strain on the Achilles. And ill-fitting shoes, especially ones with a really stiff or high-heel pad that rubs against the tendon insertion, can definitely aggravate things. And don't forget genetics. There's actually quite a strong family link. Having a family history increases your risk by about 5 times.
5 times. That's significant.
It really is. And one last specific group, certain inflammatory conditions, the ones that affect where tendons attach to bone, we call that enthesitis. Things like ankylosing spondylitis, reactive arthritis, psoriatic arthritis, they are particularly linked to insertional Achilles tendinopathy right at the heel bone.
Wow. Okay, that's a pretty comprehensive list. It feels like a lot to remember. Is there a handy way to keep track of these?
There is. Mnemonics can be super helpful here. Let's try this one. A man, poor shifter.
Okay, a man, poor shifter.
Yeah, so A for age, M for male, AN for activity, specifically jumping, running,
Okay.
P for poor biomechanics or technique, and maybe also think portly for non-sporty obesity, O for old injuries or for rapid increase in activity,
Right.
C for chronic conditions like diabetes, hypertension, H for heel wear issues, those dodgy shoes, I for increased family history risk,
Mm-hmm.
F for family history and enthesitis-related conditions, and TEAR, think RX, the prescription symbol, reminding us of quinolone antibiotics.
Man, poor shifter. Okay, I like it. It actually breaks it down nicely.
Hopefully it sticks.
Yeah, definitely useful. So we know who's at risk and what might trigger it, but what's actually going on inside the tendon? What's the pathophysiology?
Right. So the Achilles tendon is built tough. It handles huge forces, but with that repeated stress, especially if those risk factors are playing a part, you start getting tiny amounts of damage, microtrauma within the tendon fibers themselves.
Oh.
And over time, if the damage keeps happening faster than the tendon can repair itself, this can lead to a degenerative process. It's not just simple inflammation.
Ah, okay, so it's more of the tendon tissue breaking down.
Exactly. That's a key point. While, inflammation might be involved, especially early on, chronic Achilles tendinopathy is often more about these degenerative changes in the collagen fibers, the cells within the tendon.
And what does that lead to?
Well, it can result in the tendon becoming thickened. You might even feel a lump. But paradoxically, even though it's thicker, it can also be weaker, which increases the risk of partial tears or even a full rupture down the line.
And didn't you mention blood supply earlier?
Yes, that's crucial. The Achilles tendon, particularly in that mid-substance area, has a relatively poor blood supply compared to, say, muscle tissue. And that limited blood flow really hampers its ability to heal itself effectively after injury.
Right, which explains why it can become such a persistent chronic problem.
Okay. So if someone presents with pain back there, what else could be causing it? What other conditions should we be thinking about the differential diagnosis?
Yeah, super important not to jump to conclusions. We need to consider retrocalcaneal bursitis. That's inflammation of the little fluid-filled sac, the bursa, that sits between the Achilles tendon and the heel bone.
Okay, the bursa.
An injury to the plantaris muscle, that's a small muscle that runs close to the Achilles, can sometimes mimic the pain. Posterior ankle impingement, where tissues at the very back of the ankle get pinched during certain movements, like pointing the toes. Sural nerve entrapment is another one. The sural nerve runs down the back of the calf and around the outside of the heel, so if it gets trapped or irritated, it can cause pain in that region.
No, okay, so problems with the bursa, other muscles, nerves. What else? Well, you've got to consider other general ankle injuries, maybe even ankle osteoarthritis, though the pain pattern might be different. Sometimes a ruptured Baker's cyst from behind the knee can cause calf pain that might radiate downwards.
Right, the Baker's cyst.
And crucially, this is a must-not-miss deep vein thrombosis, a DVT or blood clot in the leg. While it often presents with more diffuse calf swelling and tenderness, sometimes heel pain can be a feature. You always need to rule out serious stuff like that.
Definitely. DVT is always on the radar with leg pain. Is there a quick way to kind of mentally categorize these differentials?
Yeah, maybe think about the structures right around the Achilles, the bursa, the plantaris, the nerve. Then think about the ankle joint itself, impingement, arthritis, and then broaden out to things referring pain from elsewhere or systemic issues, the Baker's cyst, and importantly, DVT. So local stuff, joint stuff, and referred systemic mimics.
That's a helpful way to frame it. Now, how common is Achilles tendinopathy? You said it's frequent, but do we have any numbers on that? What's the epidemiology look like?
Yeah, it's tricky to get exact prevalence figures for the whole population, but we know it's definitely very common, particularly in people who are active.
Right.
The notes mention a really striking statistic, though. It's estimated that long-distance runners face a lifetime risk of about 52%.
Wow, over half.
Yeah, over half of long-distance runners might experience it at some point. That really highlights just how common it is in certain groups who put repetitive strain on that tendon.
That is significant. So when someone does develop it, what are the classic signs and symptoms?
Yes.
What are the clinical features they usually describe?
Typically, it's a gradual onset of pain right there at the back of the heel or slightly above it in the tendon itself.
Not usually a sudden thing?
Not usually, more often insidious. People often find the pain gets worse after activity or maybe the next morning. Morning pain and stiffness are really common features, that difficulty getting going first thing. When you examine them, the tendon itself is usually tender if you press on it. And they'll often report pain when they actively move their ankle, especially pointing the toes down against resistance, that plantar flexion movement.
Okay. And you mentioned earlier there's one absolutely critical test we have to do during the exam.
Yes. Cannot stress this enough. You must always perform Thompson's test.
Remind us what that involves again.
You have the patient lie face down with their feet hanging off the end of the bed or kneeling on a chair. You firmly squeeze their calf muscle. Normally, the foot should automatically plantar flex point downwards.
Right.
If you squeeze the calf and the foot doesn't move, or barely moves, that's a positive Thompson's test. It strongly suggests the Achilles tendon is completely ruptured, which is a whole different ballgame, and needs urgent assessment, often surgical.
Absolutely critical check. Thompson's test. Got it. So if we suspect tendinopathy, not a rupture, what investigations might help confirm it or guide treatment?
Well, the main aims are really to confirm the diagnosis if it's not clear clinically, assess how bad the tendon looks, see if there's any tear involved, and help figure out the best treatment plan. It's usually a combination of the physical exam, functional tests, and imaging.
And what imaging do we typically use?
Ultrasound is often the first port of call. It's pretty good. It's dynamic, relatively cheap, and easy to access. It can show us if the tendon is thickened, if the fiber structure looks abnormal, or if there's any fluid, like in that retrocalcaneal bursa.
Okay.
MRI gives you much more detailed pictures. It's better at showing the extent of any degeneration or partial tears within the tendon substance itself. So we might use MRI if the diagnosis isn't certain based on clinical findings and ultrasound, or if we specifically need to rule out or quantify a partial tear before considering certain treatments.
Right. So ultrasound's a good start, MRI for more detail if needed. Okay, let's talk treatment. How do we actually manage Achilles tendinopathy? What are the main approaches?
Generally, we split it into two broad categories: conservative management, meaning non-surgical, and surgery.
And presumably we start with conservative.
Almost always, yes. Especially for early or less severe cases, the first line is conservative measures.
And what does that usually involve? The classic Rice therapy?
Sort of, but maybe mice is better now. Movement, ice, compression, elevation, but the key is relative rest or activity modification. So not complete immobilization usually, but reducing the activities that aggravate the pain. Ice can help with pain, especially after activity.
Okay.
NSAIDs, non-steroidal anti-inflammatories like ibuprofen, can be used for short periods for pain relief, although remember, the underlying issue is often more degenerative than inflammatory. Sometimes putting a small lift in the heel of the shoe, an orthotic heel lift, can temporarily reduce the strain on the tendon.
And physiotherapy.
Crucial. Physio is key. They'll guide gentle calf stretching, very important not to overdo it aggressively, and crucially, introduce those eccentric exercises.
Ah, yes, the eccentric heel drops. These seem really important. Tell us more about those.
They really are the cornerstone of rehab for mid-substance Achilles tendinopathy. The Alfredson protocol is the most well-known. It involves standing on the edge of a step and slowly lowering your heel down below the level of the step, using the non-affected leg to get back up to the start position.
Right, focusing on that lowering phase.
Exactly, the eccentric contraction. And you do it with the knee straight to target the gastrocnemius muscle, and then also with the knee slightly bent to target the deeper soleus muscle.
And how often?
The standard protocol is pretty demanding. 3 sets of 15 repetitions for both the straight knee and bent knee versions, done twice a day.
Wow, that's 180 reps a day.
It is, and it needs to be done consistently for about 3 months. It requires real dedication from the patient, but the evidence shows it's very effective for many people. It might be painful initially, but patients are usually encouraged to work through some discomfort.
3 months, twice a day. That's a big commitment. Okay, what about things like injections? Are they helpful?
The evidence is, let's say, mixed, and there are definitely cautions. Corticosteroid injections, injecting steroid right into the tendon, is generally discouraged now.
Why is that?
Because there's a significant risk it can weaken the tendon tissue and actually increase the risk of a rupture later on. Maybe okay for the bursa, but not the tendon itself.
Right, avoid steroid in the tendon. What about other injections like PRP?
Platelet-rich plasma, PRP, where they inject concentrated platelets from your own blood, is being studied. Some studies show promise, others don't. It's not yet a standard, widely proven treatment. Same for things like prolotherapy. More research is needed.
Okay, so injections are a bit uncertain. What other non-surgical things might be tried if the exercises aren't enough?
Well, sometimes combining those eccentric exercises with extracorporeal shockwave therapy, or ESWT.
Shockwave, what's that?
It uses focused acoustic pulses directed at the tendon to try and stimulate a healing response. The evidence suggests it can be beneficial, particularly when added to the exercise program for chronic cases. Autologous blood injection, injecting a small amount of the patient's own whole blood, is sometimes tried. It's considered pretty safe, but again, the evidence for effectiveness is still a bit uncertain.
Okay.
There's also some evidence for using topical glycerol trinitrate GTN patches applied over the tendon. It might help with pain for up to 6 months, possibly by improving local blood flow or affecting collagen synthesis.
GTN patches, like for angina.
The very same drug, just used topically. And in really stubborn cases that just aren't responding, sometimes a period of immobilization in a boot or even a cast might be considered to completely offload the tendon for a while, but that's less common now.
Right. And when does surgery come into the picture?
Surgery is really reserved as a last resort. It's for those cases where someone has gone through a proper, comprehensive, conservative program, usually at least 6 months of dedicated physio, including eccentrics, and they're still significantly limited by pain.
And what does surgery involve?
It depends on the exact problem and the surgeon's preference. It might involve debridement, which means cleaning up and removing the degenerated, unhealthy tendon tissue. Sometimes they release fibrous adhesions around the tendon. There are also more minimally invasive options being used now, like tendon stripping or percutaneous tenotomy, where they use needles to break up scar tissue under ultrasound guidance.
Okay.
But regardless of the specific technique or whether treatment was conservative or surgical, the rehabilitation afterwards and a very gradual planned return to activity are absolutely vital for success in preventing it from coming back.
Absolutely. Gradual return is key. So, thinking long term, what's the general outlook for someone with Achilles tendinopathy? What's the prognosis?
It really varies. It depends on factors like how severe it was to begin with, how quickly they sought treatment, how effective the treatment was for them personally, and crucially, how well they stuck to the rehab plan.
But overall,
Overall, the good news is that most people, the majority, do recover well with appropriate management and can get back to their desired activities, even high-level sport eventually.
that's encouraging.
It is. However, you do have to be realistic. Severe cases, or ones that have been neglected for a long time, can sometimes lead to persistent long-term problems, and there's always a slightly higher risk of re-injury compared to someone who's never had it.
But I think there was a positive statistic mentioned in the notes about long-term outcomes.
Yes, that's right. Reassuringly, data suggests that around 85% of patients manage to achieve complete normal function and are basically symptom-free about 8 years after their initial injury.
85% at 8 years is pretty good.
It is. It shows that while it can be a frustrating condition to treat, there's potential for really good long-term results if managed properly.
Definitely encouraging. Lastly, just to round things off, what are the potential complications we need to be aware of with Achilles tendon issues?
Well, the main ones stemming from tendinopathy itself are the development of chronic, persistent pain that impacts daily life, ongoing weakness or stiffness in the tendon and calf muscle, and that risk of recurrence, getting another bout of tendinopathy or even developing a new injury because of altered biomechanics or residual weakness, reduced overall mobility or function in the ankle and foot can be a consequence too. And as we've mentioned a few times, if the tendinopathy isn't managed well, it does increase the underlying risk of suffering a complete rupture of the Achilles tendon, which obviously carries its own set of more significant complications.
Right. So to kind of wrap this up, we've really covered the waterfront on Achilles tendinopathy. We've defined it as that chronic overuse issue of the big heel cord.
Yeah, happening either mid-substance or at the insertion.
We've gone through the many risk factors, remembering our man-port shifter, Mnemonic.
Hopefully helpful.
Definitely. And the importance of thinking about other causes like bursitis or even DVT, and always doing that Thompson's test to rule out rupture. We talked about the pathophysiology, more degeneration than inflammation, and that poor blood supply hindering healing. The typical features: gradual pain, worse after activity, morning stiffness.
And the role of ultrasound, maybe MRI, in diagnosis.
Right. Then the management, heavily focused on conservative approaches first, especially those dedicated eccentric heel drop exercises.
Offertson's protocol, yeah. 3 sets, 15 reps, twice a day for 3 months. Consistency is key.
And caution with steroid injections, maybe considering shockwave or GTN patches in some cases, with surgery as a last resort.
Exactly. And highlighting the generally positive long-term prognosis for most people, aiming for that 85% symptom-free mark eventually.
While keeping an eye out for complications like chronic pain or rupture risk.
I think that covers the key revision points really well.
Oh,
Hopefully that detailed walkthrough gives everyone a solid, memorable grasp of Achilles tendinopathy.
absolutely. And maybe a final thought for everyone listening. Considering how common this is, especially in active people, how much could early recognition, and perhaps more importantly, proactive management of training loads, avoiding those sudden spikes in activity, really influence whether this becomes a major chronic issue or just a temporary niggle? Something to ponder.
Definitely food for thought. Prevention and early intervention are always better.
Indeed. For more fantastic resources to help you ace your MSRA exams, make sure you check out passthemsra.com and also freemsra.com for free sample questions. Thanks so much for joining us for this deep dive.
Thanks for listening.